Amazing. So I get the pleasure to introduce Dr. Beau Ances. So Beau, we can't thank you enough for presenting here today. I've known Beau for a number of years, but he is the inaugural Daniel J. Brennan, MD Professor of Neurology at WashU in St. Louis and the Vice Chair of Faculty Affairs in the Department of Neurology at WashU. And really, I mean, his laboratory has been focusing on developing novel neuroimaging methods to assess changes in brain due to neurodegenerative diseases, especially cognitive changes associated with HIV. I mean, he's had numerous grants, numerous publications. If you're interested in imaging and HIV, you're bound to read Beau's work. And I am going to hand it over to you, Beau, and we're going to hear about giving hand. Got to get rid of that term, a helping hand, a role for neuroimaging. So thanks, Beau.
It's wonderful to be here. Thank you, Leah. And it's always a pleasure. And as I was saying before, to many of you, I have a strong affinity to Hopkins and Baltimore specifically since I was born there, grew up there, and then spent some time with Dr. MacArthur and others there during residency. So I really love coming and speaking to one of the leading places in the world, and Leah, Dr. Rubin, and others are doing just a bang up job. So I put this title as a tongue in cheek, just for Leah and for many of you, but I'm going to kind of discuss how I view and when I'm seeing patients in the clinic, and kind of give you an overview of where things stand in the field and go from there. So here are my disclosures. I wish I had stuff in different industries, but I don't. So I am just a simple country neurologist. So what many of you may not know is actually the first case ever of HIV in the United States, as described, is from St. Louis, and we'll talk about that. But before we get to that, I'm going to talk about what our educational objectives are, is to understand the pathophysiological changes, which many of you are literally experts in this area, the use of neuroimaging. So we'll go through a quick neuroimaging primer, so you'll be all up to speed. And then we'll take a look at different ideas of how certain contributions, not only the viral load, comorbidities, but aging and even polypharmacy. And I know many of this work has really been influenced by many of you at Hopkins and elsewhere in looking at some of these kinds of changes. And then at the end, kind of propose some new analytical methods. And this is really the work that Raha and Leah and others are really doing and leading the charge on this, and very fortunate enough to work with them, and look forward to continuing to work with them on new and exciting areas. So as I was saying, the first patient actually ever discovered in the US with HIV was in St. Louis. Yes, St. Louis. And the reason why it came about is in 1968, there was an individual, his name was initials of RR. He was a 16-year-old African-American male, had lymphedema, and he lived on Delmar Boulevard. And we'll get back to that street. And I literally live only a couple of blocks away from where he grew up. At autopsy, he was noted to have KS lesions, wasting disease, and there was really a colleague here, Dr. Memory Elvin Lewis, who was amazing. And one of the things that she did was she held on to samples and looked at these samples. And originally it was described as this wasting disease. It was not really known what the etiology was in 1973. But in 1987, they ran Western blots and actually elucidated that he had HIV. There are probably earlier cases than this case, but it just highlights thinking about this, and then even in looking in certain populations, which is key points that we need to be considering about even today when we're thinking about individuals who may be positive. So what about our hypothetical patient? And this is kind of a conglomeration of what I see now. So it's an older individual. They're in their 60s and now they're doing much better, but they're coming in with some mild cognitive changes. They're a little bit slower in doing stuff, misplacing stuff, has been diagnosed with HIV for a number of years, and also has some other comorbidities that are there, on some medications, newer medications, not yet on, say, long-acting injection medications, but on other very good medications, but been on a whole host of medications. And we do a general exam. And one of the things that I do often in the clinic is do a MoCA, Montreal Cognitive Assessment. And just as an idea, as a screen of what's going on in this individual. And he's scoring a little bit low on this test, not hugely impaired, but definitely some impairment that's present. So we're trying to rule out what are those other reversible causes of dementia. We do the whole laundry list, doing very well in those different measures. Gets an MRI, looks relatively normal, undetectable viral load, good CD4 count. And so the question is, what's causing these kinds of impairments? So when we're thinking about that, it's thinking about that kind of patient that's in your clinic or you're seeing. This is the kind of stuff that I'm constantly thinking about. So one of the major things, and we all know, is that there's this idea that HIV, how does it get across into the brain? There are multiple different ideas, either through disrupted tight junctions or through monocytes that become macrophages. And when I kind of explain this to my patients, they release evil humors that are either the viral proteins or other inflammatory changes. And then those proteins don't usually affect the neurons themselves, but instead affect the supporting cells, as we all know, the role of the astrocytes and, of course, microglia, and they become activated. And it's those changes that then may affect the neurons and may either lead it to a stunned state or actually where it's degenerating. Well, that's a little bit different than we see in Alzheimer's disease, where it's primarily the neurons that are affected. And then there's this presence of amyloid and tau changes. And then the microglia are trying to either clear this, or then actually too much of it is then leading to more of Alzheimer's disease. Now, there are relationships between HIV and Alzheimer's disease. On the left-hand side of the figure, you can see all these different kinds of mechanisms that may be in play in these individuals. And then on the right-hand side of the pathology, so in HIV-negative individuals, you don't see any of those little punctate little dots. Those are amyloid plaques that are present, which you see in HIV-positive individuals. Some of those plaques, but they're more diffuse, and we'll get back to that in a little bit later, versus below and over to the right-hand side, which are more neuritic plaques, and they look a little different that we see with Alzheimer's disease. And that may be important for some of the changes and the ways that we're able to measure this through current techniques for looking at this. But there's this question of, does HIV accelerate the aging process and also accelerate Alzheimer's disease? And I'm going to kind of try to tackle that and look at this. Now, HAND has had its time, but I do think it's maybe passing its time, and I would equate that to, and I'm going to date myself, of, I kind of call the HAND criteria the Plinko game. And if you guys have ever remember watching that on The Price is Right, where you little thing and you kind of try to figure out where you land, that's kind of how we've been characterizing HAND. So you can see in these kinds of algorithms, if you have cognitive impairment, but is it due to psychosis or delirium, we'll come back and we reevaluate you. But if it isn't due to those, then how much is the impairment due to? Is it in is it affecting your daily functioning or not? If it is not affecting your daily functioning, then you're asymptomatic. But if it is affecting your daily functioning, then you're symptomatic. And then you can either have it one or more standard deviations or two standard deviations in one domain, or one is a standard deviation on multiple different domains, and looking at these kinds of changes. And we kind of get you either into this MND or HAD. Well, that holds, but it doesn't capture the heterogeneity, doesn't capture what are these other comorbidities or other contributing factors that may be also seen in these individuals. And so I do think there is a place for the nomenclature, but at the same time, we really need to think about this and revisit some of these ideas. And then You can see in the far left-hand side all the different tests and then how we group them. And, I've had lots of discussions with Leah and others and leading experts in the world, what goes into these different domains. We can also have those whole conversations about this. So there's a role for cognitive testing, but what I'm going to try to suggest to you is that there are other markers that we can start to use, including imaging, that may also start to tease apart these different changes and how much is due to HIV versus other factors. So when we look at these kinds of differences in individuals, and we're thinking of that Alzheimer's disease versus the hand categories, one of the things we really need to think about is what areas or domains that are affected. So in Alzheimer's disease, we kind of see this more cortical involvement that's present, and then often, short-term memory and other kinds of domains that are more affected in Alzheimer's disease. In contrast, in hand or in this cognitive impairment that's due to HIV, well, in the past, before the pre-heart era, it was a lot of the psychomotor slowing, but now it's a little bit changed. It's a lot more executive dysfunction, but they could also have some psychomotor speed problems, or they may have memory problems. And the problem is that with the hand, this heterogeneity that we see, everybody kind of gets lumped together because of those cognitive domains, and if they're one or two standard deviations, but it doesn't separate them out into those various domains. That may be very important for our treatments and for kind of separating out individuals. And Leah and Raha and others at Hopkins have been really leading this charge and doing a wonderful job. You can see on the bottom of these figures is that in Alzheimer's disease, there's this gradual progression. So we used to think that Alzheimer's disease was senile dementia. Everybody got old, everybody got this cognitive impairment. The answer is actually that's not the case. Most people are doing pretty well. Yeah, they're getting a little bit slower with aging, but if you're really falling off that curve, you have a neurodegenerative process. In contrast, in hand, you can see a lot of these fluctuations. So some days they may be better, some days they may be worse, and there's a lot of fluctuations in the kinds of cognitive processes that are going on in these individuals. So there are differences between these different diseases. Why this is important is because we're really facing a silver tsunami with HIV. This is from the Swiss study, we can take this from the US, and I would bet that's the same thing at the clinic at Hopkins. But here at our clinic, over 50%, now 55, it's almost 57% of individuals are greater than the age of 50. So we are now living with a more chronic disease. And the question is, how's that affecting the body? So there's been a lot of work, this idea of frailty. I'm not going to talk a lot about that exactly today. We've been looking at that, but it seems to age the body. So if we look at bone function, if we look at liver function or cardiac function, they're all a little bit slowed or impaired in older HIV patients, to the point of a 55-year-old HIV positive individual looks like a 65-year-old HIV uninfected individual, meaning they look older than their stated age. Our real objective is look, what is happening to the brain? And I'll show you some of our results specifically through neuroimaging. Well, there's a large variety of different neuroimaging techniques that are out there. I'm going to kind of go through these kind of quickly and give you a kind of way that it could be looked at. One of the more common ways is to look at something called T1 imaging, which are structural images. So we can get these different areas of the structure. We can use programs, something called FreeSurfer, so we can look at the thickness of these areas. We can also segment these different areas and then make sure that it is segmented properly, and then come up with these very colorful, fancy figures that go onto covers of journals. But we can also look at their trajectory and see if this individual is above or below what normal, that's an air quote, normal individuals look like, and then kind of get these volumetrics. This is actually done in clinical practice right now. So I actually order my MRIs and I can ask them to look at certain structures and then tell me how that readout is. And this is actually a billable way to now look at individuals instead of just saying, well, it looks like it's a little bit smaller. I don't know. I did this kind of comparison. You actually have quantitative metrics that are now being generated. We can also look at resting states, so areas that fluctuate together or oscillate together make up different networks, and we can actually recapitulate the networks if you were actually doing a task. So we can look at networks that are involved. We put a seed in a particular area and then see this executive control, salience, attention, auditory, sensory, motor, visual, or the default mode network. Now, I hope you're not in your default mode network. That's kind of when you're daydreaming and thinking about other stuff. What am I going to do? Pick up the kids later? Do I got to go do this for go to the dry cleaners or whatever else that you may be doing that day? I'm hoping right now you're using your visual because you're looking and seeing stuff. You're also having attention that is there, and then you're also hearing me. So I hope some of these other networks are very active, but we can map out an individual while they're just sitting in the scanner doing nothing and look at these oscillations within individuals. We can also look at blood flow in individuals, and we can either tag at the neck, wait a period of time and see how much is delivered, or not tag and look at that same slice. And by comparing these two and subtracting them, we can see how much blood flow was delivered. So this is a non-invasive way to measure blood flow to individuals. And then more recently, when I say more recently, that's in the last, say, 10 or 15 years, we now have PET tracers, so positron emission tomography tracers that can look at different markers and are very sensitive to either amyloid or tau, which are those two hallmarks of the disease. And then a lot of work that has been done at by Dr. Coughlin and others at Hopkins looking at inflammatory markers using PET or radio tracers. I'm just going to talk about the two ones that we typically use for Alzheimer's disease. That's amyloid measures, and you can see on the bottom left if you're amyloid negative or amyloid positive or tau PET positive, and we can actually quantify these numbers of how many centiloids or how high you are in a particular value. All right, so let's go now we got those imaging framework, we got that kind of background that's going on. Now let's take this patient that's sitting in front of us, who's this older gentleman, and the question is, what are the key characteristics that I'm thinking of when they're there? Well, one is time, and is there this legacy effect? So how long have they been infected? How long when they were untreated? What are the effects of this acute and early HIV infection? Do they have ongoing virus? In this case, this individual is virologically well controlled, but maybe they had blips. Maybe they haven't been well controlled in the past, and now only more recently they're well controlled. They're older individuals, so we're looking at aging, and then we're thinking of, is this different than Alzheimer's disease, or is there both, or is there a combo that's going on in this individual? Well, we know that they have also hypertension, diabetes, other cardiovascular or other risk factors in these individuals. We're also then thinking of the social determinants of health, where they live, and we'll get back to that Delmar and that Delmar divide that we're seeing in individuals. And then finally, they're on medications. And as many of you know, I kind of play this game called the medication game. And I will tell you that in many of my persons living with HIV, the average is about 11 to 13 medications. I can't understand how they're able to ever do that. So one of the first things that I actually literally sit there and talk to them about are like, what are the top 5 meds that we're going to be thinking about to make sure that you're taking? Do you have a pill box? Are you reliably doing that? Because in so many cases, when we actually really ask them and really probe them, they are not always taking their medications. And there's some days just reaching into almost like a fishbowl, picking out their meds and hoping that we're getting the right meds and we're doing the right job. So we really need to be thinking about that and what certain medications may be very important or maybe want to deprescribe in these individuals. So let's think about the acute and early infection. We know he was infected in the 1990s and he's been constantly followed. So early work that I was doing before I came to WashU over 17 years ago was in San Diego with the great group that's there. Ron Eller, Scott Latender, all those groups that are real leaders in the field. I was fortunate enough to work with them. We looked at blood flow, and what you can start to see is that blood flow is diminished with acute and early HIV infection within the last 6 months. So they were HIV negative and now become HIV positive in the last 6 to 9 months. There's already a drop in these subcortical areas. And then in the visual, more cortical areas, there's a little bit of a drop, but by the time an individual becomes chronically infected, then there are already changes. And so when I tell patients, when I'm thinking about them for strokes, time equals brain, it's the same thing with infection. Time equals brain. The longer an individual is not well treated for the infection, there's more that it's going to be set up within those individuals. And I can show you that in the same thing of looking at radar plots with our work with Serena Spudic, who's also, as you may know, a really leader in the field and wonderful colleague. When we looked at some of her acute and early infection when she was at UCSF, you can see that in the putamen, this subcortical region, there's already a drop in that, and then there's an increase in the ventricle size. And if we look with using other measures called diffusion tensor imaging, the longer an individual is infected, the lower the FA, the lower those kinds of white matter connections are there. And then in individuals before they are on CART, there is this areas of blue, meaning volume loss. After they start on CART, there seems to be a plumping up of these areas, meaning that earlier you start, the more it's going to be normalized. But the later it is, there's probably some damage that's occurring. We can improve things, but we may not get all the way back to that original baseline in these individuals, aka a legacy effect. We can also do this with resting state functional connectivity, and we see these changes within individuals where it's lower in HIV positive versus HIV negative. And then even in subcortical areas, there's differences, even those that are or are not on medications. And what I'm showing you here is that in some areas in HIV positive individuals who are not on CART versus HIV positive individuals that are on CART, they don't seem to be changing as much, but in other areas, there does seem to be changes with antiretrovirals, meaning that antiretrovirals probably don't have a uniform effect throughout the brain. There are some areas that are more sensitive to those kinds of changes, and others may, because they've had a legacy or other kinds of things, or smoldering inflammation, where they're not having as much of an effect. When we look at individuals longitudinally over time, what we can see is that HIV positive individuals on average are lower than our HIV uninfected individuals, but if they are well controlled, they're having the same rate of decline, meaning that once you start on the medications, they are really a lifeline for those individuals, and they will experience the same gradual decline that HIV uninfected individuals. So again, time equals brain. Starting on medications well controlled really can make a difference within these brain volumes or other structural measures or functional measures. What about ongoing virus? So Sarah Cooley, who's a really superstar instructor who's in our group, who's been very fortunate enough to be in the STAR program and also work with Leah and others there, has looked at cognitive measures. Here are 4 different measures of 4 different groups: HIV uninfected, virologically suppressed, low-level viremia, 20 to 200 copies or greater than 200 copies. And you can see the global scores on cognition are worse. And then you can also see that virological failure, the total brain cortical volume is also reduced. So if there's active virus and it's still not well controlled, then there is an issue, and that is also leading to active kinds of changes within the brain that we can start to measure. Now, we've also been looking at this kind of idea of your biological age versus your chronological age. So you may be 60 years old, but you may look like a 50-year-old, or you may be 60 and actually look like a 70-year-old. So do you look your stated age? Do you look older or younger than your stated age? And we can kind of come up with this normative brain value or normative value, and then see if you're above the line, meaning that you look older than your stated age, or you're below the line, you look less than your stated age. And so we think with HIV, there's already going off, so you're looking older, then you're starting on antiretrovirals, it's bringing you back, but maybe not all the way back to that original baseline. And then if you are not taking your antiretrovirals, then you're even further off of that baseline. And so we wanted to kind of use these same kind of techniques and look at this brain age gap, or look if you're older or younger than your stated age. So we've just looked at aging in general, and what you can see is in this figure, as individuals get older, there is aging of their reductions in their blood flow. So as you're listening to me, there's already a reduction in your blood flow. I'm sorry that that's happening, but you can see our HIV negative are higher than our HIV positive. And if we start at a 30-year-old HIV positive individual, see where it interacts with the HIV negative individual and go down, it's about 45. So it's aging the brain by about 15 years. Similar to what we saw in the body itself. So there are changes that are going on. And then the question is, how long does it take you to get down to this level? Do you immediately go down or do you slowly go down? So we used a broken stick modeling. And what you can see is that there's about a 3-year window when individuals are slowly decreasing. What that also tells me is that if we could start an individual earlier, we could bring this black line much closer to this hash line. But the larger this effect, the more that offset, and that's going to just stay with that individual, that legacy effect within that individual. When we looked at blood flow measurements, Kaylin Peterson, who's going to be an assistant professor here, is doing some just absolutely stunning work here in neuroimaging and is working with many of the colleagues here as well. He's been looking at blood flow, and you can see that it's really, if you're undetectable, you look very similar to HIV uninfected individuals. It's really those older HIV individuals that have detectable virus that we need to be really concerned about. And you can see that even in the figures on the right-hand side, those over 50 with detectable, you see less of that oranges and reds in those figures, meaning that there's less blood flow to those individuals. So those are the people in our older population that we really need to be following very carefully, making sure they're taking their medications. And then we use that brain age gap kind of measure. You can see that in green are HIV uninfected individuals, in yellow are HIV with undetectable. They're a little bit higher than their stated age by a couple years. And then if you're not well controlled, you're even higher. So that, again, controlling the virus really makes a difference, especially in older individuals. Now, the other questions that we had, and we're talking about this with Alzheimer's disease, is can we look at that with some of these different imaging techniques, and then more recently with some of these new plasma biomarkers? When we looked at these 4 different groups here, HIV positive individual with no dementia, HIV positive individual with dementia, and HIV negative individual with no dementia, and HIV negative individual with dementia, aka Alzheimer's disease, you can see lots of these red areas, meaning that there's increases in amyloid deposition, but not in our HIV individuals with or without dementia. So we did that. And then more recently, there are these blood-based biomarkers. So what is so revolutionary in the field is that we can actually measure amyloid in the blood, and that nicely correlates with those PET images of amyloid within individuals. And so we use something called mass spectrometry to look at these kinds of changes within the blood, which seems to be the most sensitive way to look at that amyloid. If you have more amount of this amyloid in your brain, you have less amount in the blood. And you can see in Alzheimer's disease, it is lower. But in our HIV positive individuals with or without cognitive impairment, there does not seem to be a difference compared to our controls, meaning that these blood-based markers could probably be a good way to start to detect these kinds of changes within these individuals, at least potentially as a screening mechanism. Is this due to Alzheimer's disease or is this due to HIV? So we can start to follow these kinds of changes. We also did this with PET tau, and Sarah Cooley looked at that. And what you can see is that in these individuals, there's not a lot of tau uptake. There is this tau uptake in these subcortical regions, but we call that more likely to be off-target binding. But we can also kind of progress through this kinds of measures. So there's amyloid, tau, and then neurodegeneration. So we call this ATN profiling for Alzheimer's disease. We then looked at that N component in HIV individuals, and what you can see is that patients with HIV compared to uninfected individuals, there's no differences in this plasma NFL. If we looked at it by cognitive impairment within our HIV positive individuals, those with cognitive impairment do have higher amounts of NFL. NFL increases in HIV uninfected as well as infected individuals with age, and they don't seem to be any different. But those individuals that have higher NFL also have this elevated brain age gap, meaning they look older than their stated age, aka they're cognitively impaired. So we can use NFL. If it is elevated in individuals with HIV, that's kind of telling us that there's probably some cognitive impairment. But within HIV, we can't tell the difference between HIV uninfected or infected individuals with NFL itself alone. So what about other comorbidities? So co-infections, So Keelan has been looking at some of those. So we've done the Framingham scale. So that's a 10-year risk score, looking at smoking, cholesterol, blood pressure. And again, if you're above the line, meaning that you're higher than your stated age, people with HIV have a higher brain age gap than those without HIV, meaning that those cardiovascular risk factors are contributing to some of those kinds of changes. And then the same thing with hepatitis C. If you're Hep C positive, that is also contributing. So if we're treating these cardiovascular risks, if we're treating your hepatitis, we're going to also make you better. So we really need to consider those comorbidities. And that's often what I'm talking to my patients about in the clinic. What about those social determinants of health? Well, in St. Louis, and I know it also has occurred in Baltimore, but specifically in St. Louis, there was redlining, and we are still seeing the consequences to this day of redlining within St. Louis. And so here's a map, and I'm actually sitting right around here, is where I'm giving you the talk from Wash U. And we can kind of separate out the city. Those areas that are least disadvantaged are in the blues, which is right where I am right now. But there are also areas only a couple of miles away where they're most disadvantaged and where there was redlining within those areas. Well, we looked at those individuals, if they were positive or even if they were negative, and looked at if you lived in certain areas, what was your brain age gap? And the answer was you're aged by about 2 years. So worse ADI, meaning in those more disadvantaged areas, their brain is already aged by a couple of years. And so living in these environments is very, very important. How do we get those kinds of measurements? It's actually pretty simple. And I look at EPIC. I know lots of us have different opinions of EPIC, but in that little corner, you can actually look at the zip code. And by looking at the zip code, I can pretty much guess what their ADI is or how much they have access to certain kinds of things, employment, housing, education, or other areas. What about medication? So we're also thinking about that, and I'm talking to you about polypharmacy. So Sarah has also been looking at that, and what you can see is neuropsych performance with regards to these anticholinergic medications. We often prescribe them, especially to older individuals, because of COPD, Parkinson's disease, incontinence, or antiemetics. But we can also classify this anticholinergic burden or ACB scale. And you can see we can either look at none, low anticholinergic, or high anticholinergic burden. And you can see as that anticholinergic burden increases in those individuals, both positive and negative, their cognitive performance declines, as well as even their temporal lobe volume declines, especially in our HIV positive individuals. And so when I'm seeing these older individuals, if they're on anticholinergics, I try to de-prescribe if that can be done for these individuals, because I do think that this may have serious consequences in the future for those individuals. We've also looked at integrase inhibitors, and Jane O'Halloran, who's worked with many of you here, who's now in Ireland, but is just an amazing colleague. She looked at integrase inhibitors, and she looked at seeing if you were not on an INSTI or if you were on an INSTI. And what she showed is that if you were on these integrase inhibitors, they do have some association with cognitive impairment in a couple different domains, specifically learning and memory. So these medications are very important. I'm not saying that you should not be, and we should not be prescribing it, but there may often be no free lunch with some of these medications. We already know that with efavirenz and other medications. So we just need to be on the lookout for some of these medications that our individuals are on. So how do I kind of put all this together with our patients and thinking about that? What's probably a multi-hit process that's going on. So first, where an individual lives and their exposures early on and those stressors definitely are probably affecting affecting that individual and specifically affecting the brain. Then if they get infected, then there are changes. The longer they're infected without starting on antiretrovirals, that's that second hit that's going on, and that can lead to a legacy effect. Then there can be third comorbidity. So the individual is on antiretrovirals, but as he or she is getting older, there may be drugs of abuse, there may be cardiovascular frailty, all these other measures that we talked about may also lead to changes within the brain. And then the fourth hit is that as they're getting older, plus these comorbidities, they may be interacting, and so that the individual looks older than his or her stated age. And we can start to distinguish Is this due to Alzheimer's disease versus is this due to HIV with some new blood tests or other imaging markers? And then constantly thinking about how to de-prescribe in these individuals, how to reduce their burden and try to make sure that they're on the right medications, and if how many of them and how well they can continue to take them. So in our individual, we did PET scans. We didn't see large changes. They were mild impairment. They had reduced blood flow, and we wanted to consider other comorbidities that could be attributing to some of the changes that are on with this individual. So how do we move forward from this, and how do we give our field a new way or new ideas to think about this? It is really using, I don't know if I'm committing heresy by saying these words, biotypes, but it is an important way to look at our population. And you can see in this kind of figure, there's a large variety or heterogeneity that are seen in these individuals. And by collecting multiple different measures, we can use machine learning methods to start identifying features, and then by doing that, subgrouping these individuals to different subtypes. Why that's important is that we have taken a big hammer and are trying to find a nail to hit. And that hasn't really worked because we have tried lots of different antiretrovirals, other neuroprotective mechanisms, anything else, and they really haven't led to any more improvements than the antiretrovirals that we're already giving to individuals. However, we've been just classifying it as one large group. There may be some individuals that have certain kinds of changes that may be more susceptible or more amenable to certain kinds of medications or other kinds of therapies for those individuals. And so if we can split out these different groups, then we may be able to give them more targeted interventions and lead to more precision medicine within these individuals. And so that's where really the field needs to be moving. And I kind of am taking coals to Newcastle, because you've probably already heard this, is that this is where I think Hopkins and others are really leading the charge of kind of disentangling and separating out these groups. So we've done some of this kinds of work. We're using machine learning and specifically deep neural networks, actually what was recently awarded the Nobel Prize for. And we've looked at ideas of trying to separate out by cognitive impairment versus frailty within individuals and using neuroimaging techniques. And you can see that some areas, by using these deep neural networks, and we can find these hidden layers, we can find some areas that are affected by both, some areas that are really affected only with frailty, and some areas that are more affected with HIV-associated cognitive impairment. And with this, we have pretty good accuracy of disentangling. Is this more due to frailty versus is this more due to cognitive impairment? Well, Leah and Raha have also been using these same kinds of mechanisms, looking at all of these different kinds of tests, reducing them, using these kinds of self-organizing maps, phenotyping them, and you can see that there are different kinds of groups. There are some groups that are not impaired at all, some that are having more deficits in executive function, some in more learning and memory, some overall just globally impaired. And by using these kinds of groups, these may be able to separate out these different groups, and different targeted therapies would be given to an individual with global weakness versus those that have psychomotor speed or versus executive functioning. And so you could think of like CBT could be for one group, but not for another, or we give certain kinds of medications that affect certain networks, and by looking at it that way, so a network-based kinds of treatments. We've also been with Sotiris here, using a mechanism, a technique called HYDRA, which is heterogeneity through discriminative analysis to find different subtypes. So what we use is a nonlinear algorithm for classification into different subtypes. And you can see we can make these kinds of different cuts to find these different subtypes that are present. And what we start to see is 3 different clusters. So one cluster of HIV infected individuals, and you can see there are changes within the brain, and there seems to be more in the cingulum in these individuals, in the corpus callosum, and there seems to be loss in that, but they have normal values and they're cognitively stable. We see a second group where there's actually increases in brain volume within these individuals, even though in general we don't see a lot of differences between our HIV positive and HIV negative. But within our HIV positive, the group that had an increase was also associated with worse psychomotor speed, worse processing speed, and had a legacy effect, meaning that there were some changes that have happened to the individuals and they're left with those changes. And then a third group that had the worst cognitive performance, also the greatest decreases in brain volume, both cortically and subcortically, also had detectable virus. And so by using these kinds of techniques, we're now able to separate out these different groups. So I think that's where our future is going to be, using these either imaging, cognitive, or other ways, using machine learning to separate out these groups to then have more personalized medicine for them. Well, this is kind of the work that I do is really dependent upon, and I'm just a spokesperson for a larger group of individuals that I'm so fortunate enough to work with, both people in my lab, people who used to be in our lab, our global collaborators, our Alzheimer's Disease Research Center, and many of you here doing this. And then we're very fortunate to be funded through a number of different institutes at NIH, as well as other mechanisms. And I can't thank enough all of our participants. And here's ways to contact us. But I'm more than glad to take any questions. And thank you so much for your attention today.
That was awesome, Beau. Thank you. I'm going to open it up to questions. I love how you took the kind of a case and did the hypothetical and kind of walked through how all of these different factors influence a number of different imaging modalities. And it was fun to see some of the Hydra work that Aris is working on.
Thank you.
That was the comment. But anybody want to unmute themselves? You left them all speechless, Beau.
I'll start. Beau, first of all, that was really amazing. I learned a lot. I had a question. You made the comment that if A beta is higher in the brain, it's lower in plasma. And why is that? Does anybody know? Why is that the case?
Oh, sorry, so I was on mute. So what happens, let's just think about that in a second and how things are working. So we're all making A beta naturally, and typically we're clearing that out of us. And so it's not depositing in the brain, it's getting flushed out and it's going into the CSF. And then there is this translocation from the CSF to the blood and vice versa, from blood back into the CSF, okay? So there's this kind of dual communications. If you're having Alzheimer's disease, then there's more of the A beta that's depositing within the brain. There's going to be less in the CSF, and then that's going to be translated to less of this A beta 42/40 in the plasma as well. Now, there are other markers that are out there. There are newer measures, something called plasma 217, and that is another measure, and that actually is a measure of tau and tau phosphorylation. And you may be saying, wait a minute, you just said tau, but that's another hallmark of the disease. Well, where it gets phosphorylated at these different sites more correlates with amyloid. And the reverse is with tau, it increases. So usually we don't have a lot of tau, and then as a person becomes more impaired, their p-tau or their total tau starts to go up. And so in the plasma as well as in the CSF, you'll see an increase in those measures. Does that kind of make sense of how you have to think reverse engineering kind of stuff for the 42/40 versus these tau measurements that are now starting to come out?
No, that makes sense. But tau accumulates both in brain as well as CSF and plasma.
That is correct.
P-tau and A beta accumulates in the brain, but not in CSF and plasma.
Well, it is diminished in the A beta 42/40 ratio. We use the 40 as a way to normalize the 42. And what happens is that ratio decreases in the CSF with Alzheimer's disease, and that ratio decreases in the plasma with Alzheimer's disease.
All right, thanks for clarifying.
No problem. Dr. Joseph J. Mahan.
Yeah, great talk as always, Beau. I really enjoyed it.
Thank you.
I have a question about I think it was the second last slide where you were doing clustering with imaging. And so the group that did the worst had detectable virus. Is that accurate?
That's correct. Yeah. So our groups, and they had the they had shrinkage of the brain, so they had the greatest decrease in the brain. They had active virus, and they were performing the worst as well too. So by using these kinds of clustering analysis, we are able to disentangle that. And what we also saw is that if you just compared the positives versus the negatives overall in all the groups, you wouldn't see any differences. There's really very little differences between the groups. But by the clustering mechanisms, we're able to separate out these different subgroups, and those subgroups are then associated with certain factors.
So is that the virus in the CSF that you?
Yeah, that was only in the blood. We did not tap. We do have more people, and we're actually working with Trish Berto and others to look at some of those measures. We've also looked at inflammatory measures. I didn't include those, but CD163, we do see some increases within these individuals, and we're going to be looking at that more. So hold that. We're actually looking at those kinds of measures, and we're waiting for Trish to do that. We have about now almost 100 people that we've tapped.
Okay, thank you.
Thank you. Are there other questions too? These are great. Raha said, I wish I had had the opportunity to hear you give this presentation. First started working in this area. Thank you. Regarding comorbidities, there's a specific comorbidity that's common and negative impacting cognition. So that's a great question. And I don't think it's one comorbidity. We have been looking at this, and any of you who are going to the HIV and Aging Conference in DC in the next couple of days, Sarah Cooley is going to be presenting some of these results. Please go to her talk. She has actually looked at how much are contributing factors from hepatitis C overall, just itself, versus diabetes versus hypertension. And she does see changes with each of these measures, and she'll be talking about that. I don't want to steal all of her thunder for that. If you are going to that, please look at that. She's got a talk on that. Is there one? I will just say it this way. It's probably not one per se, but it's the combination. And some ways to get that kind of combination is to actually look at it through some of these kinds of risk scores or stratification scores. So you saw it one way, the Framingham, but there are other ways to also classify and to kind of understand that. And when I'm seeing patients in the office, I'm looking at their blood pressure. I'm looking at their cholesterol levels and trying to say, hey, these are things that you're doing great, or hey, we need to think about this more. I hope that answers the question. Using their machine learning algorithm, are there other imaging methods that could help categorize? And the answer is yes. And we are actually looking at that. And wow, that sounds like something for my ad. And Rob, Paul, and others are on here. But that's the idea for using and combining these different imaging modalities with the other cognitive measures to kind of generate up these phenotypes. But I know Rob's on and Leah's on, they can more eloquently talk about that. But the idea is to kind of combine multiple different imaging as well as other measures to really come up with a better understanding and characterization of individuals. I see Dr. Liang, Huaojun Liang. Please.
Oh, yes, thank you. So Dr. Beau, I have read many of your papers. So thank you for the excellent talk. So my question is about how to evaluate the cognitive function. So I know I work at the University of Maryland. I work with Dr. Linda Chen. So we also have HIV studies, and it took us 2 hours or even longer to evaluate one participant, use the battery. So we start to apply the NIH toolbox, but we don't see any references about the application of NIH toolbox in HIV. So is it possible in the future? Because the NIH toolbox is very standardized. You don't need to worry about the accent or your attitude or the interaction between you and the patients, and it's shorter and faster. So, and I want to see if there another way that to like potentially in the future we can apply similar tools to evaluate the cognitive functions in the HIV study? Thank you.
So great questions, and I know Leah can answer this much better than I'll try, and then I'll hand off to Leah or to Rob or to others on this. So first of all, there are pros and cons with any of the testing that we have. So let's just make sure we understand that. Specifically, even in NIH Toolbox, we don't have all the norms. And so that is a major limitation with some of the tests that we are doing. One of the ideas, some teams are doing this, so I know Leah is, we are doing it, but we're not doing all of the tests in the NIH Toolbox. And so one of the ideas is again, in this MyAD kind of idea, is to bring up large data sets together that do have cognitive, that do have imaging, that do have blood-based measures within these individuals, kind of use a machine learning algorithms to kind of separate out those individuals. And the goal being that we would have a reduced number of tests, aka there would be the kind of cognitive battery that would be given to individuals. Currently, we're not at that state. That is the goal of the future for doing that, and then testing that within another sample of individuals to follow that. But we're still not there. But Leah or Rob or others who want to talk about this, or much more eloquent than myself, can also go and talk about.
I think Rob's here. I have used the toolbox in some of our studies. I mean, there are norms, but I do not get good distributional data at all from the tasks that I've actually implemented. I've used brain baseline assessment of cognition and everyday function, where there are tasks where we do get really good distributions. It's kind of, I think at this point, a mix between paper and pencil, computerized assessments, some of the more what I would consider in alignment with the research domain criteria that kind of fall outside of just the cognitive domains. But I think we're kind of at the point where there are certain tests that, standard neuropsychs in declarative memory and the like, that are helpful, but we really need to figure out what are the essential assessments that are needed, right? And I think we're kind of in some ways a little bit back to the drawing board because of all of the comorbidities and social determinants and everything else that's happening. I'll let Rob unmute.
Just also say we're using the RDoc methods and as well too, and trying to incorporate the NIMH's ideas for RDocs and doing that, and hopefully more will be incorporated or using those kinds of methods. But Rob, it's so good to see you, and also in St. Louis, so it's nice, a colleague and close collaborator.
Yeah, I mean, just a comment on the value. There's definitely value of having some of those computerized measures, getting reaction time and understanding reaction time variability. And then as Beau noted and Leah knows very well, that those options for the really digging into the RDoc constructs are really much stronger with those kinds of measures. On the flip side, I would throw out a caution that just sometimes folks might think that computerized assessment is kind of it runs autopilot, but in fact it still requires really good oversight from research assistants and staff to assure that people understand the task instructions, and that simple things like fingernails touching the screen that aren't registering an actual tap, for example, because of the length of the nail, little details like that can end up resulting in really bad data if it's not managed in a way that still has some time, intensity, and labor needed by the research team itself. But I do agree that there's an opportunity for this kind of more of a hybrid approach, maintaining some of those really important clinical measures that we have historically leaned on, but also tapping into the RDoc constructs and getting into some of those computerized measures for the more nuanced outcome measures.
And just add on to that for one other point, is just that there also may be a role for ecological momentary assessments, meaning sending out blitzes to individuals that can be doing on their phones if they have the capabilities and the technology, and get a little bit more of a feeling, because there's always that idea that when you come in and you have this white coat and you're being tested in these things that are not as natural. So if we can make it more natural in the setting, that can also improve and lead to more reliable results too. I see Dr. Jiang, Wei Jiang.
So,
Dr.
Bo, can I answer
Oh,
something?
Pim, I'm so sorry. Yes, Pim, please go ahead. Thank you.
Sorry, going for you, Wei, but this is to follow up on the previous part. As one of the developers of the toolbox, I just want to say that the amount of time and money needed in order to get norms, particularly for the toolbox, one of the things that we tried was to make a continuous measure that could be given to anyone between 3 years of age and 80 or 85 years of age, is a huge undertaking, and it only could be done for the toolbox because 10 institutes at NIH went together as part of the neuroscience blueprint to put money in that. So it's nice to develop new tests and so forth, but to get a norming that basically goes across the ages with reasonable numbers, both in English and Spanish, is a huge undertaking. And I don't know whether, even if you do this, whether you can get a distribution that Leah is looking for.
Just normal distributions. I mean, I'm just looking for, I mean, we're struggling and it's in about 150. And you still have to pay for it.
No,
Just,
I
I mean,
understand,
that's
but
the other thing, just
the
some
question
folks-
is whether that has to do with your test or whether that has to do with your population.
Yeah, I mean, these are Max and Y's and Baltimore folks, so they're not just, you know what I mean? I was surprised.
Okay.
But
Maybe we
again,
should
it's
talk
not the
offline,
format.
Leah, because I'm really, as well, I'm really, since we're still kind of looking at further developing this, there's now a baby toolbox and so forth coming out as well, to just make sure that in future generations it's working better. But
Well,
thank
Yeah, and I'm
thank you, Pam,
happy to
for all your
share.
help too.
Yeah, I'm
We
happy
can't
to
thank you
share
enough.
anything we've collected. Sorry, Dr.
Is that my turn?
Yeah, sorry.
Yeah, no, don't be sorry. Thank you so much. This is a very intriguing study. So I have a question. The data show plasma A beta 42 versus 40 ratio is higher in the plasma in HIV and CSF and enter into the brain compared to Alzheimer's disease. Is this suggesting that there's a more A beta 42 production in the peripheral or in the system in HIV? If this is true, if
So the
if-
plasma markers are one way to look at that. The plasma markers, I was trying to show you, is that they're no different than the uninfected controls. There is plasma A beta 42 that is made in the periphery that will affect that. And the plasma markers are also sensitive to other measures, including creatinine and kidney clearance. And so there are multiple steps to be considering when looking at any plasma markers as a test. We are hoping that in the future that A, they will be approved as an FDA test, but B, that these plasma markers more likely than not will be run as a screening test. And then in future, we will then use the PET imaging or other measures. Right now, in most clinical trials that are looking at in Alzheimer's disease, the plasma markers are a secondary endpoint. The primary endpoints have been PET imaging and PET amyloid measures to look at that, or PET tau measurements. And so they are, quote, the gold standard for evaluating amyloid that's present. I can get into a whole different things. I do a lot of work on Alzheimer's disease. I can tell you that the plasma markers are good, but they're not perfect. Neither is PET. And there's probably a dynamic range of when they are most sensitive. Remember, these are in femtomolar kinds of concentrations, so it's very small concentrations that you're measuring in some of these plasma markers. You have to have it done by certain techniques. I will tell you that there are differences if you run this on a Simoa versus Quanterix versus LumiPulse versus mass spec. And there have now been studies that have shown that. We chose the mass spec, which is what's been developed here at WashU, and specifically at a group that's about 2 blocks down called C2N. It's the most sensitive of the measures for plasma, it seems to be, but there's a wide variety. And so you need to be eyes wide open when you're using these plasma markers.
Do you know any causes or driver for the systemic production of A beta 42?
Yeah, you can have amyloid systemically being also made. You can also have amyloid that's depositing systemically. So you can have it in your heart, and you can also have it in your blood vessels. And so some of that, if it goes into the blood vessels, can actually lead to certain kinds of bleeding or other kinds of changes. And then the amyloid can also be systemically depositing with amyloidosis within the nerves as well as within the heart.
I mean, which induce amyloid beta 42?
I'm sorry, say that again?
What induce, which causes is for amyloid beta induction in the peripheral blood?
It can be many different sources. I can't give you one particular source.
Okay, thank you.
Regarding comorbidities, there are specific comorbidities that are negatively impacting cognition. I think I tried to answer that. It's mostly due to hypertension, diabetes, hepatitis. Those are the ones that we've looked at. And then I do think that there's some other ones that are out there. There was somebody who was asking, Dr. Dash was asking, what are your thoughts of using animal models of the disease mimicking them? I'm not sure if you're regarding the HIV or if you're regarding Alzheimer's disease. The HIV animal models, different people have their favorite ones to use. I don't do as much work on the animal model area. There are pros and cons of various animal models. I would not be the one that could answer that. With regards to Alzheimer's disease, most animals don't develop Alzheimer's disease, so mice don't develop it. We have to actually induce it by giving them amyloid or giving them tau and crossbreeding to generate it. Those look more like the autosomal dominant or the genetic forms of Alzheimer's disease. So there are little differences between some of those. And again, I don't do as much work in those areas, so I would defer to others for what is their favorite animal model to look at. Dr. Jiang, did you have another question?
I know we're a
No,
few after the hour.
we're
So
after the
Beau,
hour.
I just wanted to say thank you for an amazing and super comprehensive talk. It led to, the questions at the end were great.
It's awesome.
And yeah, and so we had a cancellation for next week due to unforeseen circumstances. So we will not have one next week unless, somebody magically contacts me and wants to present. And otherwise we'll see everybody the week after. And Caroline, do you know who's speaking?
Yes, it's Hannah Wilkins.
Okay.
So
I don't know if we have a title to talk yet, but anyway, thank you everybody for participating, and we'll see you in 2 weeks.
Bye-bye.
Great job.
Thank you.
Appreciate it. Yeah.